Biologics in the treatment of asthma, targeting the dartboard. Dr. Jalal Mohsin Uddin. DTCD, FCPS Pulmonology. Assistant Professor. NIDCH Freedom from disease burden. Yet to achieve. 50% of people with severe asthma feel they are not achieving treatment goals. 60% of people with severe asthma believe that the goal of reducing reliever medication is not close to being achieved. 24% of people with severe asthma feel the goal of no emergency visits set by GINA is not being achieved. 96% daily asthma symptoms. 86% nighttime awakenings. Daily symptoms and nighttime awakenings are a burden for the majority of individuals with inadequately controlled severe allergic asthma (SAA). Challenges in asthma management. Despite optimal standard therapy, there is an unmet need for people with severe asthma that remain uncontrolled, incur significant medical burden and healthcare costs. Challenges in asthma management continue. Severe asthma is a heterogeneous airway disorder with complex pathophysiological mechanisms which can be broadly divided into type 2 T2 high and T2 low inflammatory pathways. Recent advances in asthma therapeutics with the advent of biologics have heralded an era of promising targeted therapy in this group of patients. Why we need targeted therapy. Overall reduction in asthma burden. Suitability for renal or hepatic impaired patients. Established long-term efficacy. Highly selective for their target molecules. Benefits of targeted therapy. What is biologics? Biologic drugs. Produced from living organisms or contains components of living organism through long, expensive research and highly complex process. Biologics in asthma. Currently there are 4 popular biologics for severe asthma. Omalizumab, mepolizumab, reslizumab and benralizumab. Allergic asthma, eosinophilic asthma. Omalizumab is indicated for severe allergic asthma. And the other 3 biologics, mepolizumab, reslizumab, and benralizumab, are indicated for severe eosinophilic asthma. Another recommended tupilumab, which is indicated in adults and adolescents 12 years and older as add-on maintenance treatment for severe asthma with type 2 inflammation. What is allergic asthma? Allergic asthma is the most common type, affecting around 60% of people with asthma. 300 million asthma patients. Both allergic and non-allergic asthma have the same symptoms, such as shortness of breath and wheezing. But allergic asthma patients have more coughing, sneezing, allergic rhinitis and allergic conjunctivitis. What is eosinophilic asthma? People with eosinophilic asthma don't tend to have allergies. What sets this type apart from other forms of the condition is a higher number of eosinophils in blood, lung tissue, and sputum. With eosinophilic asthma, the entire respiratory system from the sinuses to the deepest part of the lungs can become inflamed and obstructed. Mechanism of action of biologics in asthma. Common characteristics of biologics. The asthma biologics work in a targeted way by disrupting pathways that lead to lung inflammation to reduce asthma attacks, improve symptoms, and reduce dependency on oral steroids. They are given as an injection or infusion depending on which biologic is being taken regularly in hospital or patients can self-inject at home. Common benefits of biologics. Reduced need for steroids and therefore reduced associated side effects, reduced asthma attacks and asthma-related hospital admissions, improvement in symptoms and quality of life, improvement in lung function. A common case of asthma. Asthma history. Asthma diagnosed at age of 14. Allergies. Perennial allergic rhinitis, dust mites, grass pollen, cat dog dander. Comorbidities: history of atopic dermatitis, symptoms, current treatment, type I diabetes, persistent rhinoconjunctivitis, increased wheezing, both day and night, breathlessness, reduced lung function, limitation of daily activities. High-dose budesonide formoterol bid, montelukast OD, oral prednisone PRN, intermittent for 6 months, concern regarding diabetes risk. Current status: breathless on effort, nighttime. Awakenings at least twice a month, coughing in the morning, severe exacerbations requiring hospitalization, increased prednisone use. Omalizumab anti-IgE, 2003 approved for severe allergic asthma. 2014 approved for chronic spontaneous urticaria. 2019 approved for nasal polyp. Dose: 150 to 300 mg every 2 to 4 weekly. SC suggested initial trial 12 to 16 weeks. Recognize patients suitable for omalizumab. GINA and ATS based questions. Are your symptoms waking you at night? Are you experiencing disruptive symptoms more than twice a week? Do your asthma symptoms dramatically restrict your daily life? Have you had 3 or more courses of OCS in the past year? Have you admitted to hospital because of your asthma in the past year? Have you used rescue medication more than twice in the past week? Have you had 2 or more severe asthma attacks in the past year? Tests: skin prick test, FEV1 80% for adults only. Serum free IgE levels: 100 IU/ml, 1500 IU/ml or more. Omalizumab EUS MPC 2015. Global Initiative for Asthma GINA 2015. Global Strategy for Asthma Management and Prevention. Available at www.ginasthma.org. Documents for date accessed, June 2015. American Thoracic Society 2000. Proceedings of the ATS Workshop on Refractory Asthma. AMJ Resper Crit Care Field 162, 2341-51. Role of omalizumab. Medication: omalizumab. It is a humanized monoclonal IgG antibody against IgE, with low immunogenicity. Target: IgE. Indication for asthma: moderate to severe allergic asthma. Age group: greater than or equal to 6 years. Role of omalizumab. Continue. Dosing and administration: 75 to 600 mg subcutaneously, 2 to 4 weeks interval according to IgE level and body weight. Efficacy: downward arrow asthma exacerbation, downward arrow asthma symptoms, downward arrow seasonal exacerbation, downward arrow need for ICS, improve FEV1, improve quality of life. Role of omalizumab. Continue. Adverse effect: anaphylaxis 0.2%, headache, pharyngitis, reactions in injection site. Biomarkers for primary selection of patient: IgE level 30 to 1500 IU/ml, increase specific IgE level against perennial allergens, FeNO 30 ppb. Role of mepolizumab. Medication: mepolizumab, a humanized monoclonal antibody mAb against IL-5 which selectively inhibits eosinophilic inflammation and reduces the amount of eosinophils. This reduction is seen in both sputum and blood. Target: IL-5. Indication for asthma: severe eosinophilic asthma and age, greater than or equal to 6 YRS. Dosing and administration: 100 mg subcutaneously 4 weekly. Role of mepolizumab. Continue. Efficacy: downward arrow asthma exacerbation, downward arrow asthma symptoms, downward arrow need for IES, improve FEV1, improve quality of life. Adverse effect: headache, pharyngitis, reactions in injection site, hypersensitivity reaction. Biomarkers for primary selection of patient, blood eosinophil 150 to 300 cells μl. Role of reslizumab. Medication, reslizumab. Target, IL-5. Elevated levels of eosinophils increase the risk for asthma exacerbations. By targeting the IL-5 and disrupting its signaling pathways, reslizumab aims to inhibit eosinophil maturation and promote programmed cell death. Indication for asthma, severe eosinophilic asthma and age greater than or equal to 18 years. Dosing and administration, 3 mg kg, IV, 4 weekly. Role of reslizumab continue. Efficacy, downward arrow asthma exacerbation, downward arrow asthma symptoms, downward arrow need for ICS, improve FEV1, improve quality of life. Adverse effect, pharyngitis, increase CPK 20%, myalgia 1%, anaphylaxis 1%. Biomarkers for primary selection of patient, blood eosinophil 400 cells μl. Role of benralizumab. Medication, benralizumab is a humanized, fucosylated, monoclonal antibody. Target, IL-5R. Indication for asthma, severe eosinophilic asthma and age greater than or equal to 12 years. Dosing and administration, 30 mg, subcutaneously, 4 weekly for first 3 doses followed by 30 mg 8 weekly. Role of benralizumab continue. Efficacy, downward arrow asthma exacerbation, downward arrow asthma symptoms, downward arrow need for ICS, improve FEV1, improve quality of life. Adverse effect, pharyngitis, headache, reaction to injection site, hypersensitivity reaction. Biomarkers for primary selection of patient, blood eosinophil 300 cells μl. Role of dupilumab. Medication, dupilumab is a fully humanized monoclonal antibody, capable of inhibiting intracellular signaling of interleukin IL-4 and IL-13. This molecule, together with other pro-inflammatory cytokines such as IL-5, play a pivotal role in airway inflammatory response defined as type 2T2 inflammation. Target, IL-4 and IL-13. Role of dupilumab continue. Indication for asthma, moderate to severe eosinophilic asthma and age greater than or equal to 12 years. Dosing and administration, initial dose 400 to 600 mg, then 200 to 300 mg subcutaneously, 2 weekly. Role of dupilumab continue. Efficacy, downward arrow asthma exacerbation, improve FEV1. Adverse effect, pharyngitis, anaphylaxis, hypersensitivity reaction. Biomarkers for primary selection of patient, blood eosinophil 150 cells μl. Adults and adolescents 12+ years. Personalized asthma management. Assess, adjust, review for individual patient needs. Combination of diagnosis if necessary, symptom control and modifiable. Risk factors including lung function. Comorbidities. Inhaler technique and adherence, patient preferences and goals. Symptoms, exacerbations, side effects, lung function. Patient satisfaction. Treatment of modifiable risk factors and comorbidities. Non-pharmacological strategies. Asthma medications adjust down up between tracks, education and skills training. Step 5. Controller and preferred reliever. Track 1. Using ICS formoterol as reliever reduces the risk of exacerbations compared with using a SAVA reliever. Steps 1 to 2. As needed, low-dose ICS formoterol. Step 3. Low-dose maintenance ICS formoterol. Step 4. Medium-dose maintenance ICS formoterol. Step 5. Add-on LAMA refer for phenotypic assessment plus or minus anti-IgE, anti-IL-5-5R, anti-IL-4R. Consider high-dose ICS formoterol reliever, as needed low-dose ICS formoterol controller and alternative reliever. Track 2. Before considering a regimen with SABA reliever, check if the patient is likely to be adherent with daily controller. Step 1. Take ICS whenever SABA taken. Step 2. Low-dose maintenance ICS. Step 3. Low-dose maintenance ICS LABA. Step 4. Medium-high dose maintenance ICS LABA. Step 5. Add-on LAMA. Refer for phenotypic assessment plus or minus anti-IgE, anti-IL-5-5R, anti-IL-4R. Consider high-dose ICS LABA. Other controller options for either track. Low-dose ICS whenever SABA taken, or daily LTRA, or add HDMS-LIT. Medium-dose ICS, or add LTRA, or add HDMS-LIT. Add LAMA or LTRA or HDMS-LIT, or switch to high-dose ICS. Add azithromycin adults or LTRA, add low-dose OCS but consider side effects. Children 6 to 11 years. Personalized asthma management. Assess, adjust, review. Confirmation of diagnosis if necessary. Symptom control and modifiable. Risk factors including lung function, comorbidities, inhaler technique and adherence, child and parent preferences and goals, symptoms, exacerbations, side effects, lung function, child and parent satisfaction, treatment of modifiable risk factors and morbidities, non-pharmacological strategies. Asthma medications, adjust down or up, education and skills training. Asthma medication options, adjust treatment up and down for individual child's needs. Preferred controller. To prevent exacerbations and control symptoms. Step 1. Low-dose ICS taken whenever SABA taken. Step 2. Daily low-dose inhaled corticosteroid ICS. See table of ICS dose ranges for children. Step 3. Low-dose ICS LABA, or medium-dose ICS, or very low-dose ICS formoterol maintenance and reliever MART. Step 4. Medium-dose ICS LABA, or low-dose ICS formoterol maintenance and reliever therapy MART. Refer for expert advice. Step 5. Refer for phenotypic assessment. Plus or minus higher dose ICS LABA or add-on therapy, e.g. anti-IgE. Other controller options. Consider daily low-dose ICS, daily leukotriene receptor antagonist LTRA, or low-dose ICS taken whenever SABA taken. Low-dose ICS plus LTRA, add chiotropium or add LTRA, add-on anti-IL-5, or add-on low-dose OCS, but consider side effects. Reliever. As needed, short-acting beta-2 agonist ICS or ICS formoterol reliever for MART as above. Very low dose, but form 106 mcg. Low dose, but for 206 mcg metered doses. Decision chart of using biologics in different endophenotypes of severe asthma. A, B and C correspond to the available levels of evidence. Decision chart continue. The current indication of omalizumab in atopic asthma zone includes the allergic background to perennial allergen with increased total IgE level 30 or 76 QL1 according to country, whereas concomitant eosinophilic green zone inflammation increases the chance of response. Decision chart continue. The role of local IgE in atopic asthma needs further exploration, whereas eosinophilia blue zone clearly predicts response to anti-interleukin IL-5. In contrast, T helper Th2 low phenotypes gray zone have no targeted therapies, but might benefit from emerging therapeutic options. Summary. The most prominent severe asthma phenotype are allergic and eosinophilic asthma, affecting over 2/3 of patients, many of whom are unable to lead active lives because of inadequately controlled disease. Positive skin prick test, serum free IgE levels 30, IU-mil 1500, IU-mil, sputum, and peripheral circulatory eosinophil count are important for patient selection, from 0-6 years and above asthma patients for using biologics. Summary continue. GINA recommends omalizumab anti-IL-5 as the preferred step 5 add-on treatment choice, before initiation of long-term OCS use. Omalizumab and other biologics reduces asthma exacerbations, OCS use, and hospital admission rates, as well as improving asthma symptoms and quality of life, both in RCTs and the real-world setting. Omalizumab acts to free up to 90% of responding patients from exacerbations at 2 years, resulting long-term treatment cost-effectiveness. Thank you all. 42nd Annual General Meeting and Scientific Conference, Biologics in the Treatment of Asthma, Tarting the Dartboard. Learning Pulmonology.